We can hear you, Larry, but when you're not speaking, if you can just put your phone on mute. I'm not sure if you have the ability to do that, but that would be helpful. Anyone that's calling in on the phone, if you can mute yourself, it causes a lot of background noise if people aren't on mute.
Okay. Let me know if you can't hear me. I'm going to mute right now, okay?
Thank you. We can hear you.
Okay, I'm not sure why my audio is so bad, but I think we will go ahead and proceed, and if it becomes a problem, I will hop out when somebody else is presenting and hop back in and try and, I think I'm in the web platform, Mel, instead of the app for some reason, and it's not great, but I don't know why I opened it this way. So anyways, I'm sorry for the technology challenges, and I think we're now at about 82 people. Would you like to go ahead and get started? You're on mute.
Now, can you hear me now? Okay,
yes.
Very good. Okay, we'll go forward. Again, let me welcome everyone to this meeting of the Medicaid Advisory Committee. I know we had a few technological problems, and we did have a few people who did get notification that the meeting was canceled, but that's certainly not the case. And with 82 people on board, it's obvious we know that the meeting's going to happen. So let me direct your attention to the meeting protocols. I'll turn it over to you, Nicole.
Great. Thank you, Mr. Chair. Good to see you. Thanks. Christina is telling us that we still have an echo. So, Larry, I don't know if you're able to mute. Okay. Is that better? Eileen says maybe. Uh-oh. Okay. Christina says yes. Okay. All right. We're going to do our best here. Meeting protocols, if we can go ahead and advance the slides. Again, I think folks are very familiar, but please do mute microphones. I think that's what ends up giving the feedback if you're not speaking. Please do update your name and address. If you believe you're not getting correct information, you can pop that into the chat, and we will take a recording of that and make sure that we update information for folks. For committee members who have questions during the presentation, please feel free to ask your question. Either use the function to raise your hand, or go ahead and just put your question into the chat, and I will do my best to monitor them, and we'll ask Melody also to call out to me if there are questions in there that I am not catching. We will use the chat function also for public comments at the end of the meeting. So as a reminder, the public comment portion allows interested parties the opportunity to ask their questions or provide comments based on the items presented. And so we would very much encourage that public engagement. So feel free to put your question in the chat and then include your name, affiliation, email address, and comment, just in case it's something we can't address in the meeting. That gives us an opportunity to follow up with you afterwards. And then finally, presenters, don't forget to ask to transition between slides. And lastly, this meeting is being recorded. So if you are not comfortable with that, please feel free to exit. But that does help us in transcribing the minutes following the meeting. Okay. I believe then we are going to move over to the roll call and yes, introduction. Thank you. And I think we had folks pop their name into the chat the last time. However, I was made aware that that was problematic because some folks had dialed in and so weren't able to put their name into the chat. So I am just going to go through. Mr. Chair, if it's all right with you, I have the list here, and I will go ahead and just do a roll call of the of the members, and we will leave it at that.
Thank you, Nicole. That'll work.
Okay, great. So let me start at the top here. So if you can just come off mute and let us know that you're here, or pop it into the chat if you are on, and that's easier, that's fine as well. We'll keep an eye on it. So Sylvia Barella, sorry if I'm mispronouncing folks' names. Okay, Troy Clark. Eileen Good.
I'm here, thank you.
Thanks, Eileen. Megan Larino.
Yes, I'm here.
Megan, Dr. Madden. Okay, Rodney McNeese.
I'm here, thanks.
Hi, Rodney. Carolyn Montoya.
I'm here also.
Hello. Sharon Finarelli. Nancy Rodriguez. Dr. Chandler. Dale Tinker.
I'm here.
Hi, Dale. Vincente Vargas.
I'm here.
Hi. Superintendent Toll. Okay, do we have representation from the Department of Health? Okay, and the Children, Youth, and Families Department? Aging and Long-Term Services?
I'm here, it's Katrina.
Hi, Secretary. Let's see, Western Sky, Latha?
I'm here, good afternoon.
Good afternoon. Liz Locator from Presbyterian?
Hi, Nicole, I'm here.
Hi, Liz. Ruby Ann Escobar, LFC? Okay, Jeff Bustamante?
I'm here.
Hey, Jeff. And let's see, Christina Lever, I think I saw you.
I'm here.
Thank you, ma'am. Carol Luna Anderson?
Yes, I'm here.
Okay. Sarisha Main or other CLP representation? I think I saw one of you.
I'm here. Thank you.
Hi, Sarisha. Great. Kurt Rager?
Yes, I'm here.
Thanks. Great. Gary Hossapian?
I'm here.
Thanks. Ellen Leitzer? Buffy and Saavedra or AARP representation? Okay, Travis Renville? Or other Natani representation? Okay, and Anthony Yeppa?
Here.
Thank you, sir. All right, that's it. If we skipped over someone and you were here representing somebody, please just put that into the chat and we will mark down your attendance. Okay, I think we are ready to move forward. Yes?
I just want to say Ruby Ann is here. We just didn't hear her say she was here.
Okay, thank you.
Wow. We were getting some feedback there. Let me go to item 3 on the agenda, item 4 on the agenda. I believe everyone did receive a copy of the agenda. Are there any changes anyone wishes to make? It's a pretty full one. Okay. Okay, if not, I will entertain a motion to approve the agenda as distributed.
This is Carol Luna Anderson. I so move.
Thank you, Carol. Do I have a second?
Rodney
Dale
McNeese,
Tinker, I'll second.
Okay, thank you very much. Okay, is there any discussion? Seeing there's none, we'll vote on it. All those in favor of the motion to approve the agenda, please signify by saying aye.
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 Is anyone opposed? Are there any abstentions? Okay, then the agenda is adopted. Okay, I'll direct your attention to the meetings minutes from the previous meeting. Those were the August meeting minutes. Are there any changes, corrections that need to be made to that document? Okay, seeing that there are none, I will entertain a motion to approve the minutes of the previous meeting.
This is Eileen Good. I will make that motion.
Thank you, Eileen. Do I have a second to that motion? Let's not be shy.
Katrina, I second it.
Okay, we have a second to that motion. Thank you. Is there any discussion? Hearing that there's none, I'll entertain a motion. We'll have a vote. All those in favor of approving the minutes of the previous meeting, please signify by saying aye.
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 Are there any opposed? Are there any abstentions? Okay, hearing none, the minutes of the previous meeting have been approved. Okay, and then I will turn it over to you, either Nicole or Elisa Walker-Moran. So,
Thank
for
you.
item
I think I'm
number-
going to just start out really briefly, and then I'm going to, Elisa and I will kind of go back and forth here during the budget section. I think as you all saw, the agenda is fairly lengthy. It is busy over here, and we just want to keep you all abreast of all the activities going on and make sure that we are appropriately communicating with you all. That said, you are our advisory body, and so if you ever have suggestions about how you'd prefer to have the meetings run or topics that you feel like we aren't addressing that you would like to hear about, please do share those, and we'll talk a little bit more about that at the end, but I wanted to say it now so you could all be kind of thinking of it and maybe have some ideas to share when we get to the end of the agenda here today. So we are going to talk to you all about the most recent budget projection. We just completed that projection at the end of October. And then we're going to talk to you about how that kind of falls out into the Medicaid priorities for 2022. There's a few of those that are pretty critical that we want to speak to y'all about. One is provider rate benchmarking. The next is, of course, our home and community-based services spending plan. We have some exciting announcements about 988 implementation and planning, which hopefully you've been hearing about. The status of our 1115 Demonstration Waiver amendment. The Kevin S. settlement, which is, again, the settlement that's related to children in state custody and the provision of their care by HSD in partnership with CYFD. And then we wanted to give you a MISER update. That is our Medicaid Management Information System Replacement Project. It had been a while since we talked to you about the status of that project, and a lot is happening, and I feel like really starting to hit its stride there. So we wanted to let you know about those activities and how specifically they might impact some of you on one of the modules that's coming under development here in the very near future. Other couple things that are kind of newsworthy and things that we thought that you might have on your mind and have questions for us about, so we put them in here. wanted to talk to you all about the coverage options for the evacuees or refugee population out of Afghanistan and what we are doing as an agency around that population. Then wanted to talk to you all about the COVID-19 vaccination work group and the efforts that have been underway there. I know a lot of you have actually been participating in that, and I'm so grateful for that, and happy to know that those meetings have been going well. We'll talk to folks there. And then finally, as I mentioned, wanted to talk to you all about the 2022 MAC meeting schedule in accordance with the bylaws, and then give you all maybe some tentative agenda items for the next meeting and get some feedback. So that's what we have ahead. I also just wanted to call out at the beginning of the meeting, because folks may have heard this already, we did talk to the legislature about this, and then also there was a smaller press release. For those of you who don't know, my husband is JAG, Judge Advocate General for the Army, and he's in the Reserve Corps, but he had been working on a capital litigation case for about 4 years prior to us coming out to New Mexico. And that case has progressed through kind of all of the levels of appeal. He's a major at the Defense Appellate Division, and it is now kind of at their last level before what is the Supreme Court within the military. And with the kind of last motion moving that case forward, they have ordered the military him to return to Virginia to finish out that case. So he was assigned a contract of a year to complete that work. And we actually it's been a long conversation. We knew that this might happen, but it finally kind of came to fruition here at kind of mid-October, and now final orders. Actually, we just got this morning asking him to report for duty on November 21st at Fort Belvoir. So I have been working really closely with folks in our Office of the Secretary, as well as leadership across HSD and the legislature, as well as, of course, the governor's office, to outline a plan for me to continue to work remotely for hopefully the duration of that contract, at which time we would return to New Mexico. Because this is military orders, we would remain residents of the state of New Mexico. We vote here, we pay taxes here. That's the way that being, a military member works. And we are really grateful for the support of everyone who's reached out and letting us know. I know this is pretty non-conventional to have a Medicaid director out of state for a period of time, but I'll be coming back every month, and that'll be, there was a question about this at LFC that didn't get answered, so I'll clear it up, but we'll be flying back, I'll be flying back once a month on our dime, not state dollars, and otherwise as needed. So for example, for the legislative session, I'll be here more than just that one time a month. We plan to, I'll probably be out here for a longer period, most of the 30-day session. And then we'll reassess at the 6-month mark if there's any problems and if we need to change the arrangement. So I am incredibly committed to this role and to New Mexico and to all of you, and really appreciate the opportunity to continue here. But that said, like I said, I know it's unconventional, and so if any of you have questions or concerns, please do reach out and let us know, and I'll be happy to address any of that. I will probably be trying to work a little earlier in the morning and cut off sometime earlier in the afternoon, but still very committed to being where we need to be for Mountain Standard Time as well. So I just wanted to make sure to let you all know about that change in case you hadn't heard. And again, like I said, I think you all have my cell phone number and my email. Feel free to reach out with any questions or concerns. With that,
thank you for that information,
Nicole. Go ahead.
And let me just say that I certainly hope it works out well. We would certainly like to keep you.
Thank you. I really appreciate that. And I feel like it's been a pretty unbelievable few years since we got here in 2019, and I'm certainly proud of the work that the team has done and that I've been able to do with them. But there's so much more that we want to do still in partnership with all of you. And so again, I'm just really appreciative of of the opportunity to hopefully get to continue in this role and then return to New Mexico. So thanks for that. I really appreciate it. And for the notes in the comment as well, in the comments. Thank you. Okay, so let's talk about the budget. So we are gonna, mission and goals, I'm sorry, I'm moving slides ahead here. But again, you all know that our mission is to transform lives, working with all of you. It has become even more important during the pandemic. And I just wanna say at the outset that I couldn't be more proud of our team. You know, I think you all are hearing challenges in staffing in all areas. Certainly, I know those of you in the direct provision of healthcare services are experiencing this, and we are too. Folks are, you know, burning out. It's a lot of work for a long time. And I just want to thank our team for their commitment to that mission and those goals, and making sure that we continue to serve the now growing and large number of individuals on Medicaid here in New Mexico. So let's go ahead and move forward. Thank you. We can move forward again. And I am going to hop in and out, but I'm going to actually mute myself here and let Elisa take the lead on the budget.
Thank you, Nicole. Good afternoon, everyone. I'm Elisa Walker-Moran. So we're going to get right into the budget. So we're going to go over the public health emergency update. We're going to go through enrollment and the 3 years that we're projecting and the risk factors in the budget. Next slide, please. Okay, as you all know, we do produce this budget projection quarterly, and primarily the economists from at MAD produce it with help from everybody at MAD. For this projection, we only updated the managed care lines. We pretty much did a very thorough, significant update for the June projection, which was used for the budget submission for fiscal year 23. So we only did a partial update this time around. Some of the assumptions are, as you've probably heard, the public health emergency was extended one more time and through January 2016. And therefore, we do receive the 6.2 enhanced FMAP for one more quarter through March 31st. And then we begin what's built into the projection, our 3-month roll-off starting April. And we'll get into that a little more when we get to those slides. Okay, next slide, please. Okay, I believe this may have passed this weekend, Nicole, but we have the Build Back Better Act. And it does require states to keep individuals enrolled in Medicaid after the public health emergency ends. But it does have a continuous enrollment requirement through, I believe it's September. So we have to keep some of those MOE individuals on for a longer period of time. They have to be on for at least 12 months before we can roll them off. And then, you know, you can read that to yourself, but the one thing that has been proposed in this bill is this phase down FMAP. So as I mentioned, because the PHE has been extended, we do get the 6.2 through the first quarter of calendar year 2022. Then it decreases to 3% in the second quarter, followed by 1.5% in the third quarter, and then expires in the fourth quarter of the end of the year. So that's what was proposed in the bill. And then we do receive an extra 3% for the adult expansion population. So we receive 90% for that population, and they are proposing to give us 93% through calendar year 2025. Now, these additional FMAPs do assist us with the MOE roll-off, but it doesn't completely compensate for the increase in cost from these members being on Medicaid. And so what we've built into the projection is rolling off members who are income ineligible based on the most recent income data we have. And then we'll start the process of reviewing their income eligibility and contacting these members as required by CMS. Okay.
Yeah, Lisa, I'll just jump in for 1 second. Yeah, so I just wanted to clarify for folks, there's been a number of pieces of federal legislation that have helped Medicaid agencies respond to the pandemic, as you all have kind of seen throughout the past 2 years. This next larger bill that I'm sure you all are seeing in the news has a significant number of Medicaid provisions, like Elisa highlighted. These are a few that we're watching. We don't expect them to change, but you will see this little caveat on the bottom of all of our slides at this point as it relates to the PHE and the roll-off and what the funding is going to look like. It is just continuously changing at this point. So I think that this was signed by the House over the weekend, but we don't expect a full passage. I think the timeline that they're looking at is a little bit around mid-month is what I'm seeing so far. So kind of, again, highlights is just that this sets a kind of cadence that states weren't directed towards previously of when we would have to start to reassess individuals on the population and then roll off the individuals who are no longer eligible for Medicaid. That would begin now for sure on April 1st, and it seems to decouple that from the public health emergency declaration. That's new. FCRA, the legislation that we've all been talking about to date, tied those two things together. So this is a big change in that regard. And then it puts a cadence around it. You'll see on that. I know this is way too much text on this slide. We'll work on it. But the second from the bottom bullet on the left-hand side basically says that we would have to roll off 1/12 of that population that fits the criteria that's outlined there between April and September. And then at that time, states will kind of be at their own discretion. And that aligns with the dollars that you see on the right-hand side in the graph. Basically, they said, we're going to cadence you states at 1/12 of your population per month for the duration of the time that we continue to give you enhanced FMAP. After that, states are kind of at their own discretion because they know that many of us are all facing these shortfalls as a result of the large enrollment numbers and pandemic challenges Medicaid programs are facing across the country. And then Elisa hit on that 93%. Another thing that we're watching, and then we'll move forward, is that the bill actually outlines the postpartum Medicaid extension from 60 days to 12 months as a mandatory Medicaid benefit. So that would change the way that we kind of approach this as we head into session. Right now, it is still a state option that we would pursue through a state plan amendment, and that is certainly our intent at this time. But if this legislation passes, it would no longer that would be something that would be pursuing as an option. It would just be built into the state's Medicaid program. So we'll keep you all abreast of these changes, but this really does change our overall kind of planning around how we intended to approach that maintenance of effort population at the end of the public health emergency. So all things in flux until we see this bill make its way through. So we're going to let you know about our assumptions on this projection, but just keep in mind that much of this will change probably before we talk to you all again in January. Go ahead, Elisa. Did we lose you? You're on mute.
Oh, sorry. I thought I was unmuted. Okay, next slide, please. Okay, one more slide. All right, so here, as you can see, this is the 7th public health emergency extension. So each extension is for 90 days. So as I mentioned, it was effective October 18th. It expires January 16th right now, unless they choose to end it sooner. But right now, the 90 days brings us through January 16th, giving us that 6.2% FMAP through the end of that quarter. Okay, and as Nicole mentioned, all our projections are built on CMS guidance, our requirements under the MOE, based on, receiving the 6.2. So obviously every quarter we meet, it's subject to change, and it has changed. The last time we met, the public health emergency was only in effect, the 6.2 was only in effect through December. Now it's in effect through March. Okay, next slide, please. Okay, so this is just the progression of the FMAP. You've seen this chart before. We now have the final federal fiscal year 23 FMAPs. Previously, we were using the preliminary. So just briefly, we receive a preliminary FMAP calculation in the spring, and then in September, we receive the final FMAP calculation. So now the federal fiscal year 23 FMAP will not change, but it did affect what we submitted in our FY23 budget request, because we had built it with a slightly higher FMAP. And so the FMAP came in slightly lower because of higher incomes than originally projected. And there's a whole calculation behind it. I won't get into it. But our FMAP came in slightly lower, so that increased our general fund request slightly. Okay, next slide, please. Okay, so for federal fiscal year 22 FMAP, we did receive the 6.2 for the entire 4 quarters. So the state, but for state fiscal year 22, right now we have 3 quarters of the 6.2, 1 quarter without the 6.2. That's the last quarter of state fiscal year 22. So for every dollar the state invests, we receive about $4.34 from the federal government due to the FMAP, the EFMAP, and the expansion FFPs. Okay, next slide. For federal fiscal year 23, and so for the state fiscal year blend for 23, we expect to decrease to $3.57 return on every dollar, because there is no more 6.2% in state fiscal year 23. Now, if we do receive that phase down FMAP that we were talking about, that would change this slightly, but it's only 1.5% for that first quarter in state fiscal year 23. So it wouldn't change this significantly, but it would increase it slightly. Okay, next slide. Okay, this is just a visual representation of what the FMAP and the blended rate has done over time. So the top solid lines, which go with the left axis, the percent, is the percent FMAP and EFMAP and the OAG blend. And the dark orange line is the blended state FFP. So you can see that it increased, and then the last little bit of the line, you can see that's where we expect our blend to decrease when we come into state fiscal year 23. The dash lines at the bottom are the dollar multiplier that I touched on the earlier slides. So as you can see, also the dollars that we receive from the federal government begin to decline as that 6.2% expires. Next slide. Okay. So this slide shows you right now our maintenance of effort population. So we keep talking about, because of, as a condition of receiving the 6.2, we are obligated to keep individuals on Medicaid unless they voluntarily drop off Medicaid because they get private insurance, or they leave the state, or they pass away. And so right now our MOE population is just over 290,000 individuals. Based on preliminary income data, we do think we have about 85,000 individuals that could potentially be income ineligible. And we've actually built in a rolling off around 64,000 individuals because we've done a little bit closer analysis, and some of those 85,000s might move to other income categories or other eligibility categories. So right now we've looked at rolling off 64,000 individuals. And our population as of September 2021 was about 951,000 individuals, and that includes full benefit and partial benefit enrollees. Next slide, please.
I'm just going to jump in for a second here. I think this is the first time that you all have seen those updated numbers. So the last time we talked to you, those were significantly less. Our population has continued to grow, and I can now say it. I wasn't saying it before, but unprecedented fashion, because the 2014 growth after the Affordable Care Act really had kind of continued to stay above this pandemic growth, but we've now surpassed that. And what you saw in that last slide is just trying to give folks a sense of how significant that growth is. And then what we really have outlined as kind of this MOE population based on the data that we have. Again, all of that will have to be assessed at the end of the public health emergency, and we would follow all of the federal rules around redeterminations and renewals for that entire population before anything would change as it relates to their eligibility and enrollment. So it's a little confusing, I think, for folks to hear. There's 200,000 some odd MOE individuals, but 80,000 of them are income ineligible. And so I just wanted to help kind of clarify what we mean when we say the MOE population. So when we talk about that maintenance of effort population in its entirety, there's two large groups within that population. So one group that's outlined here is the population that we actually know to no longer be eligible. So either based on the income data that we have or based on some other eligibility criteria, for example, their age. So they've aged out of the category that they're eligible for if they're 18 turning 19. That is population one listed right there. And then the other population or group, I should say, to stay consistent with my slide, is the population that we've continued to extend renewal dates for. So Medicaid eligibility is 12 months. We then contact members and say, it's time for you to renew your eligibility with us. We need you to validate the information that we have and that we pulled from our data sources. And during the public health emergency, if folks have failed to complete that renewal process, we of course have not terminated them. We've just continued to extend them in 3-month increments, because at the beginning of this, as you all may remember, maybe naively, we also did not know that this would go this long. And so we were thinking in 3-month time periods, because that is the time frame of the public health emergency declarations. And so we were trying to stay tied there. So that population may still be eligible. So that's kind of the bulk of that 290,000 Elisa was speaking about. We think they're still eligible for Medicaid. But that other group, based on the data that we have, we believe they're no longer eligible for Medicaid maybe at all, or they're eligible but for a different category, and we need to move them into the appropriate category when the PHE ends. So that's why it's this overarching larger number, and a subset of that we believe will roll off at the end of the PHE. I just want to help make that clear for folks. I know it was causing some confusion even internally when we were explaining it to folks. All right, go ahead, Elisa.
Okay, I'll let you talk about the next slide. Could you move to the next slide, please?
Okay, thank you. So this is now perhaps wishful thinking, having seen the language that made it into the Build Back Better Act, but the National Association of Medicaid Directors, as well as the 4 other public policy organizations that you see listed at the top of the letter that's imaged there, had actually written to HHS and Congress, and had also been organizing with our own congressional delegation from New Mexico and others to try to help Congress understand the impact of this kind of cliff off of federal revenue at the end of the public health emergency, while we have a very large population that has come on as a result of that maintenance of effort requirement and stayed on. That's particularly true in a managed care state. We pay a per member per month capitation rate to our managed care organizations. Our average per member per month cap rate is about $600 is what we use. And so you can imagine the cost of what is now almost 110,000, I believe it's about 108,000 people coming on since the beginning of the public health emergency at $600 per member per month. That's a huge cost to a Medicaid program. And that 6.2% federal revenue has sustained our budget need, and you'll see a slide that depicts that later on. But as we near the end of the public health emergency, what we'll be speaking with you all about, and certainly the governor's office and the legislature and LFC, is that we will see this kind of drop off of that federal revenue, and then a very abrupt need for state general fund revenue to absorb that, while we carefully and appropriately try to move these folks to the appropriate source of coverage. That roll off that you all saw on the slide, the little graph that was green up on the right hand corner of what's in the Build Back Better Act, it's going to help, but it won't actually cover our costs in their entirety. And so what these health policy organizations had requested was that Congress actually allow the 6.2% for 12 months following the PHE, and then a 3-month roll off. We got the 3-month roll off, but not the 12 months in between. We're still holding out hope. We know there's some folks that are still trying to help support states with Congress, but not really expecting a lot of change in the language at this point. We had also asked similarly that as of July 1st, 2022, they sunset the maintenance of effort requirement, mostly to give states budgeting and enrollment projection stability. As you all have seen, as we've talked about the budget with you all, it's a lot of uncertainty, a lot of volatility. It makes it very hard to feel confident in your projections. And so that was really why folks were asking for a decoupling of that maintenance of effort requirement with the public health emergency declaration. It looks like that may be what is happening in the language that we see so far, but it's not that explicit. So we'll just keep an eye on it for now. But we had put this slide in prior to that legislation passing and, being routed. It's not passed, being routed, and we will again kind of hope for some additional federal revenue because it will create some challenges for us from a budget perspective. Go ahead and move forward.
Nicole?
Yeah.
We have a question in the chat asking for the estimated number of people that will be rolled off.
Thanks, Mel. So the last time we talked to you all, it was between 60 and 70,000. It is now closer to about 82 to 85,000 individuals that are likely no longer eligible. All right, Elisa.
Okay, thank you. All right, so now we're going to go into review the 3-year projection. So last time we presented the FY20 through 22 projection, and we were preparing our budget request. So this will be the first time you see the FY23 outside of the budget request submission. And we're no longer presenting FY20 because we've established our final projection, and then we established IB&R based on that, and we'll just book expenditures against that projection. Okay, and go ahead and next slide. Yep. So just a reminder, this projection is built off 3-month MOE roll-off. As you've heard, depending on what the guidance is from CMS and the support we will see in terms of revenue to support the roll-off, it could be as long as a 12-month roll-off, but for this purpose, we've built in the 3-month MOE roll-off. So just keep in mind, the longer we take to roll off these income ineligible individuals, the higher our cost will be in the Medicaid program. Okay, So here in front of you is the expenditure projection, the overall. So for fiscal year 21, with data through September, we are now at just over a $7.3 billion expenditure projection. We increased the projection by about $32 million. Most of this was because we reviewed all our contract costs, and we were making sure that they were reflected correctly on the program versus the admin projection. And we did find one that is, it's a 1 year, it's a new contract, it was only for 1 year. And we should have had it reflected in the program costs, so we added that. But this doesn't affect our general fund requests significantly because it's mostly funded with a 90% match. So it affects the bottom line by, I believe, about $3 million. Okay. For state fiscal year 22, our projection is almost $7.8 billion, an increase of about $164 million from the previous projection. Most of this is because of the extension of the PHE. So what that means is, as we've discussed, the MOE population now has to stay on the Medicaid rolls for 3 more months. That increases our costs for the remaining year. It also impacts fiscal year 23 because now we start with a higher baseline of folks that are now eligible for Medicaid than we had before. Okay, for fiscal year 23, our projection is just over $7.9 billion, an increase of $107 million from the previous projection. Again, mostly due to that MOE. And then a couple other changes. We've now included every quarter that we meet, we now have the healthcare provider, healthcare affordability tax included in this projection. We had it included last time, but we had included an old number, so we've updated it. It changes every time the managed care projection changes because it's tied it's tied to the capitation payments that we made. So just a reminder, that's that tax that increased from 1% to 3.75%. So that's now included in the projection. Okay, so now we're going to move to the revenue slide. Next slide. Okay, in terms of revenues and our general fund need, in fiscal year 21, our general fund need is almost $908 million. A change of $3.2 million from the previous projection, again, due to that additional contract. For fiscal year 22, our general fund need is almost $1.1 billion, a change of $33 million. So our projected shortfall is $54 million. So a change from 21 when we had 4 quarters of 6.2, in which case we have a surplus of $45.4 million. Now for 22, we still have a shortfall, but because of the, along with the extension, the cost of the MOE, we do receive the 6.2 for another quarter. So it does offset some of the costs. So it has reduced our shortfall, but not completely eliminated it. For fiscal year 23, so our need right now above the fiscal year 22 appropriation, so we don't have a 23 appropriation, we just have what we've requested. So we've requested almost $1.3 billion in general fund. So as compared to the FY22 appropriation, our need is $280 million. Okay, next slide. These are some of the expansion requests that have been built into our FY23 projection. We've built in the extending the postpartum from 3 months to 12 months. It does start April 1st of 2022, so it does impact minimally, but it does impact 1 quarter of fiscal year 22. But the majority of the impact, of course, for the 12 months would be on fiscal year 23. So we've built that in. We've built in the high fidelity wraparound cost as a result of the Kevin S. There are other Kevin S requirements that have not been built in at this point because we're still doing the analysis and working with the co-neutrals on those estimates. We have built in a GME expansion. We've also built in the maternal child health code changes into this projection. And then, so this is the program projection. On the admin, we've also included a primary care council expansion amount. Okay, next slide. So these are the primary drivers of what's pushing our FY23 request. So we have the shortfall from 22. Let me go in order. So our FY23 shortfall is 280 million. The majority of the driver is because we have a lower FMAP for fiscal year 23. So that 6.2% that we have been receiving through the PHE has reduced our general fund need. That expires. So 202 million of that is purely just from changes in the FMAP. Nothing we did in our program, no expansions, just purely FMAP changes from the federal government. We have an existing shortfall in 22. Part of that shortfall in 22 is also because of the 6.2 expiring in the last quarter of the fiscal year. So that's a big driver of that shortfall as well. We do have some other changes in the MAD program, increases in costs, managed care costs from normal increases in medical care costs, higher enrollment than before the pandemic, and then again the expansion items that were presented on the previous slide. For this purpose, the Healthcare Affordability Fund that I mentioned, it is built into the projection, but in terms of revenue, it doesn't affect our general fund because we do represent it as another revenue transfer. So we do expect revenue to compensate for this higher cost, but not to be built into our base general fund request. Okay, next slide.
Thanks, Lisa. I just want to clarify for folks, like the reason we felt like it was so important to give folks a visual of that is when you see that $280 million number, it's easy to think, what is happening over there? Why do you all have such a giant shortfall? And I think you all understand the growth in the program from the enrollment, but I think it's really critical to see those drivers and see that it's really the shift in revenue that we'll experience as a state that's responsible for about 72% of that shortfall is really driven by federal revenues dropping, and we still have a lot of people to take care of, and we have to come up with the state revenue to support that, at least for a period of time, as folks get situated in the correct source of coverage at the end of the PHE. So hope that makes sense to folks. I know that sometimes we rattle these numbers off and budgets are overwhelming at this size. So just wanted to give you all a sense of what's really happening here on the program side. And this is another visual representation. Elisa, I'll let you take back over.
Okay, thanks, Nicole. Yeah, so this is, if you look at the left-hand column, you see the Medicaid expenditure. So those are the dollars. So the shaded parts of the graph. So the gray is the federal share. And as you can see, we wanted to highlight for you what's going on in 22 and 23. So even though the cost of the Medicaid program is increasing slightly, we're going from about $7.8 to $7.9 billion budget, it's not increasing at the rate it was previously. Yet our, general fund is increasing from just over 1 billion to almost 1.3 billion because our federal funds are decreasing. And so this is just another visual to explain what Nicole just mentioned again, that it's nothing we're doing in our program. We're not expanding significantly or providing additional benefits beyond what was required, but our general fund need is just changing because the federal funds are expiring. So just, and we wanted to point that out because we have been lucky enough to receive that 6.2 for an extended period of time. And so our base budget was reduced accordingly. And so now our base budget has to come back up because we no longer benefit from that federal funding. So that's why we wanted to present this many ways to make it clear. All right, next slide. Okay, next slide. All right, so where are we at with our enrollment projection? So as I briefly mentioned, in September, we do have just over 951,000 beneficiaries, full benefit and partial benefit in Medicaid. We do anticipate to grow another about 10,000 to about 961,000 by December. And keep in mind, this is based on the September projection. I know we're already in November, but we updated this based on September data. By March, when we will, just before the MOE requirement ends, we will have reached 969,000 enrollees. And then after that, we'll decline as we start rolling off those individuals. We have almost 83% of our members enrolled in managed care. So the managed care lines really are our cost drivers. About 45% of New Mexicans are enrolled in Medicaid, and we, as for context, 40% were enrolled before the PHE began. Almost 40% of our beneficiaries are children, and 62% of New Mexico children are enrolled in Medicaid. And 71% of newborns in New Mexico. Now we are doing a little more analysis on that newborn data. So I think next time we meet, we'll probably present you a little more information about newborns, but not for this projection. Okay, next slide. All right, so all of this projection is built off what's been happening with the public health emergency, the extinctions, the MOE population, the unemployment and employment data. We follow that very closely. Of course, you know, those who are employed and unemployed, and how much income they receive has a direct impact on whether people are eligible for Medicaid. So we do monitor that. And of course, as we've mentioned, the MOE eligibility redeterminations. So I think, is someone asking a question, or did they unmute by accident?
Sir, Amy kept asking and asking and asking to meet with me. And I could put our, obviously did
Reminder to mute, please.
on P, much less meet with
Okay,
her.
next slide,
Then
please.
she got on me again.
Carolyn? There we go.
I muted her, thanks.
Thank you. I've done that many times, accidentally unmuted myself, so. Okay, so this is the visual that we always present of the Medicaid enrollment. For us, the PHE really began to affect Medicaid in March of 2020. So we've been in this situation almost a year and a half. And the projection, the yellow bar, is because the projection is with real data through September. And so after that, everything is projected. And then right now, we anticipate the end of the PHE at the end of March. Okay, next slide. Next slide. Okay, this is the all our beneficiaries, the partial beneficiaries and the full beneficiaries. So by June of 2020, we did have about 937,000 individuals on the rolls. The last column, and I've mentioned this before, but just to point it out. So for us, since we began seeing the enrollment impact of the PHE starting in March, our pre-PHE period is February of 2020. So since that period of time, our enrollment of June grew by 12.3%. So you can see how significantly the PHE has impacted us. We've experienced significant growth in our membership. Next slide, please. So by September, you can see we had grown by to 13.9%. By March of 22, when the MOE expires, we project to have grown by 16%. So significant enrollment growth. And then after that, you can see in the second to right column, our expected roll-off based on those income ineligible beneficiaries. Okay, next slide. So for fiscal year 23, we do expect to decline to about 918,000 individuals at the end of fiscal year 23. Okay, next slide. One more slide. So now we're going to go into the managed care enrollment. And the reason we present to you a managed care enrollment projection as well as the total beneficiaries is because this is the primary cost driver for our projection. And every beneficiary is directly tied to a cost. And so in order to produce our cost projection, we do provide an enrollment projection and multiply it by the cost of each beneficiaries. It's oversimplifying how the projection is produced, but this is why we present you the managed care enrollment projection. So in fiscal year 21, you can see we had, by the end of June, we had almost 776,000 individuals in managed care, and we had grown about 14.4% in managed care since the PHE began. Okay, next slide. By September of 21, the data that was included in this projection, we did have about 787,000 individuals and had grown about 16.1%. By March, we expect to grow to about 19.4% and have about almost 810,000 beneficiaries. And then after that, you can see our expected roll-off of those income ineligible folks. And you can see our member months. So at the bottom, it just sums all the member months. Year over year growth in member months was about 459,000 member months from fiscal year 21 to 22. Next slide. So for fiscal year 23, as those folks begin to roll off and right now the economy continues to improve, we will see a decline of about 425,000 member months. So that's in the bottom second right-hand column. So you will see some savings built into our projection from lower member months, but an increase because medical costs continue to increase. Okay, next slide. Okay, next. All right, so what are some of the risk factors built into the budget? Of course, the expectations of the MOE eligibility redeterminations, workforce participation, the high fidelity wraparound, as I mentioned, was built in. The Affordability Fund appropriation was built in, so it affects half of year of fiscal year 22 and the full 12 months for fiscal year 23. Extending the postpartum Medicaid from 60 days to 12 months. As I mentioned before, extending the MOE for 3 months. So I just want to go back to that there is a risk. The longer we have to roll off these MOE individuals, the higher cost for Medicaid. So we've just built in the 3 months right now, pending final direction from CMS. The Build Back Better plan that Nicole and I went over. What have we not built in? We have not built in any cost containment. We have not built in the MOE roll-off for 12 months. We have not built in the cost of the refugee resettlement population. Just to a comment, there are a few refugees already in Medicaid, so those are reflected in the projection. But if any, the cost of additional refugees are not built in. We are looking at providing ventilator, wing, and nursing facilities coverage. That hasn't been built in because we're still analyzing the cost of that. The cost of administering the vaccinations and the PHE extended. Okay, next slide. Okay, thank you. And I'm going to turn it over to Nicole.
Thanks. I just wanted to add one note on that risk factor slide, and we'll talk a little bit about it later in the presentation. There's a note for the refugee population. The reason it's listed as a risk is, for those of you who may have been following, there's a very large number of refugees residing at bases that are technically within New Mexico. We did not build in the cost of the entirety of that population. We're working with Lutheran Family Services, so I think it's on today, but working closely with them. And once individuals decide to reside in New Mexico permanently, then we are enrolling them into the program. So it's still a very small number. I don't even think it's in the double digits yet of individuals who've decided to stay here in New Mexico. But because we've taken that approach, that is why it's just still listed as a risk line rather than a total cost being built in, because we're just not sure how many folks will stay at this time. So no intent around not covering those folks, just waiting for them to actually move off base and settle here in New Mexico. So we can move to the next section. It looks like, so you already did, we are on the MCO procurement. So this is a section where we just wanted to talk to y'all about some of the really big things ahead in 22. And we've mentioned these in the previous meeting, but felt like worth giving an update on and letting you all know kind of some of the engagement to date. So two very significant things happen for the Medicaid program as we head into calendar year 22. The managed care re-procurement will take place throughout calendar year 22 and calendar year 23 with the awarded managed care organizations beginning their new contract in January of 2024. Now, that feels very far out, I know, but time flies, and especially when you're this busy, and procurements take a long time. So we will be working very closely with our actuaries and a designated project manager who will be directing that procurement as we head into the new year. We had talked previously, and I think I may have said to this group, so I just wanted to refine a little, that we expected to have that RFP out fairly early in 2022 because of what will show up on the next slide here, which is the 1115 waiver and renewal, which you all will recall is the federal authority under which we operate the entirety of the managed care program and most of the kind of unique structures of New Mexico Medicaid. So that is actually up for renewal, and as a result, what we will do is focus on kind of the initial program statement piece that will kind of form what we will apply for that 1115 waiver renewal for in the very early months of 2022. And then the procurement work will begin simultaneously, but we expect as a result to have the RFP come out closer to the middle June, probably at the latest of 2022 is the way the schedules are looking right now. So these 1115 demonstration waivers are also very significant undertakings, and they are approved in 5-year increments. So this one actually runs through the end of December 31st of 2023, but we have to begin the work on it next year. So these are just very significant projects that really kind of shape the way that our program will look for years ahead. And for that reason, very important for us to have input and feedback from you all as well. So the next MAC will be pretty heavily focused on the legislative session and the budget. All right, give me 1 second. There's a note in the chat. I want to make sure I didn't misstate something. Finalize the procurement in late 22 with readiness in 23, and the new contracts go into effect in 24. Or issue the procurement in late 22. Okay, I'm sorry, I'm reading the question in the chat. We intend to issue the RFP, put the RFP out in around June of 2022. Hope that clarifies, Sharon. Feel free to pop up another chat. Contracts would be awarded towards the end of the year, readiness throughout 23, and then in 24, we would start the new contracts. Okay, so thanks. So then what I was saying is that in the next MAC, with you all in January, that would be our legislative session MAC. And I think that we'll want to decide, we might do a survey monkey of you all about whether or not folks would like to be in person or not. We'll have to see how things look at that time. And I know that normally we've held that at the Roundhouse, and then we had another venue in the year before last, but we'll do that survey as we get closer and work to try to accommodate folks. It does sound like as of right now, a lot of session is intended to be in person, certainly still with mask wearing and CDC compliance. But I think that that meeting will heavily be focused on the budget and the legislative session. So the meeting that follows, I think, would be our opportunity to walk through the full timelines with you all. And to talk about the opportunities for stakeholder engagement and get your feedback on how you want to be a part of this process. I just think this is so important that we have you all weigh in. This is, again, like I said, really how we will shape the look and feel of our Medicaid program for the next 3 to 5 years, depending on which piece you're talking about, the contract or the waiver. So we can go ahead and move forward. And talk about strategic planning. So a lot of other priorities in 2022, but those are kind of the big overarching tasks ahead. They are efforts that take the entire team, and I wasn't here for the last one, but a lot of our team was, of course, and have some level of post-traumatic stress, I believe, from doing them at the same time, and with the workload we have now and some still diminished resources that we're working to recover, it's going to be a lot. So we're just really trying to plan ahead and be really open with folks about the demands so that folks understand where we're at as you're trying to engage with us on perhaps other efforts. So we also wanted to talk to you about the strategic plan overall and what's ahead for us. So this outlines some of our other priorities for 2022 and 23. We have 4 goals that you always see at the beginning of our slide presentation. And under those 4 goals, HSD has objectives for each division. So for example, my partners over at the Income Support Division have objectives and then tactics that they're responsible for to achieve that goal. And we do too here in Medicaid. So what we did was pull out, Melody, awesomely pulled out the objectives for us from the strategic plan to highlight for you all some of the things that are ahead. This is not an all-inclusive list. There's a lot going on, but these are some of those that impact the department at large and that we thought were critical for you to see. So listed here under goal 1, and it's the longest, so don't worry, all these slides don't have this much text, but this goal is obviously our kind of main focus here at Medicaid, and that's to improve the value and range of services that we provide to make sure that every New Mexican who's qualified is receiving timely and accurate benefits. So we want to ensure that as the largest payer in the state, Medicaid is providing appropriate payment for services. You'll see our tactic that falls out of that in a slide that follows and how we're trying to achieve that. Know that that's work that we started in 2019. Pandemic came, budgets took a depression, and so we have not been working on adjusting rates or really how we can shore those up where they needed to be. But now we feel like we hope we are in a place as a state and as a program where we'll be slowly climbing out of that shortfall, and we can start to address some programmatic needs that we know are long-standing. There's some other opportunities to do that with federal funds, and we'll highlight that as we move forward as well. The other is to promote primary care expansion in New Mexico. Our GME efforts remain underway under that objective, as does our engagement with the Primary Care Council, which we know many of you participate in. We want to increase our insurance options for the currently uninsured. That focus has shifted certainly since we arrived in 2019, and now we are working in close partnership with the state-based exchange. They are live and exchanging accounts with us, which is great news. In 2014, that would have been a major task that everyone was focused on, but here in 2021, it's just something that's happening on the side because we have so much going on. But we are effectively exchanging individuals' information with the state-based exchange, which went live just a few weeks ago, and I know Jeffrey had to step away, but I just want to congratulate their team and thank Lorelei for being our champion on the Medicaid side for making sure that that engagement has occurred. And so what that will do is allow us to hopefully optimize that kind of situating into another source of coverage of those folks who are no longer eligible for Medicaid at the end of the PHE, like we kept talking about. There are folks who may be eligible for for employer-sponsored coverage, who maybe lost a job during the pandemic, came onto the Medicaid rolls, but since have received a job with coverage and so no longer need us. But there are others who maybe got a job that just takes them up just above Medicaid thresholds for income eligibility. And so we really want to make sure that we help them transition into the exchange, that now, especially with federal investment, and the investment that came out of the legislature last session, means that I think at least for this year, folks with incomes up to 150% of the federal poverty level can get coverage with that still $0 premiums, which is fantastic, and I think will help folks kind of smoothly come out of this longer period being on the Medicaid rolls. Next is to support the Department of Health with the development of the DD waiver revisions. So we'll talk more about that in a minute when we get to HCBS. To employ all federal flexibility related to the PHE. I want to highlight here that we've heard some concern that folks think that the telehealth flexibilities and reimbursements will go away at the end of the PHE. Not the case. We have every intention of continuing those to the full extent of our capability. Now, if there are federal barriers, obviously we cannot overcome those, but we will do everything within our power to extend those flexibilities and reimbursements. Design and maintain a high-value managed care Medicaid program. Again, there's a lot of revisions and work that we've been doing with our MCO partners in the last year, and we intend to continue those. We'll highlight some more of that later. And then finally, implementing the American Rescue Plan enhanced FMAP opportunity for home and community-based services. Go ahead and move forward. So goal 2 is really our goal about how we engage with folks externally. It's to create effective, transparent communication and enhance public trust. It's something that is so important to us in the role that we serve. It's something that we've been trying to build as we came on as a new administration, and something that we want to continue to do. So establishing regular communication channels with stakeholders. Obviously, this is one of our main channels with you all, but we've been talking about some ways to break out into kind of smaller groups so that we have more of a back and forth engagement. These meetings end up obviously feeling like a lot of us reporting out to you all, and we want to hear from you. So we'll be working on that in the year ahead. We want to keep folks informed about the public health emergency and Medicaid programmatic changes. It is very complex and ever changing, as you know, and so we take our responsibility seriously there to make sure that that messaging is going out. We hope that folks feel informed, and we apologize for those of you who hear us talk about it in too many engagements. I know it's a repeat for some of you. And then we want to utilize performance measures to improve the managed care organization's performance, and also outcomes as a result in both physical and behavioral health. If you haven't checked it out already, HSD has an online scorecard now, where we are always publicly displaying where we are and trying to hold ourselves to a higher standard, so that folks can always go on and see kind of a pretty significant number of measures and where the MCOs all sit against those measures, and then where we do as a program as well. In addition to that, CMS is also publishing a scorecard on Medicaid agencies across the country, and we're going to share that link as well so that folks can see how New Mexico stacks up against other state Medicaid programs. We can go ahead and move forward. Thank you. So goal 3 focuses around technology and trying to really invest there to make things simpler for folks. Folks already have complex lives when they're needing access to these services, and the last thing they need is to be waiting for long periods of time or being bounced around phone call centers to get the services they need. And so we really want to try to make sure that we are automating wherever possible and making sure that we're streamlining things and using technology to the best of our ability. So we are continuing to provide requirements, obviously, to the folks on the IT side as public health emergency requirements change, and we are having to change things on the system side as a result. I talked about integrating with the state-based exchange, and then finally, in the year ahead, we'll be hopefully closing out phase 2 of the implementation of our electronic visit verification system, and then also working on the implementation of the federal interoperability requirements that we know also impact many of you providers. Finally, goal 4 is about our internal communication and engagement with our staff. We can't do any of this without them, and so we want to promote an environment of mutual respect, trust, and open communication and help them grow. As a part of the goal above that, the IT goal, we will be working with our staff in the year ahead as we really kick into high gear on the MISER implementation to think about what that means for our staffing and how we can hopefully, with increased automation, take advantage of that and allow folks to think more analytically and move processes off of them that are kind of rote, repetitive processes that a system can take care of instead, and allow our team to step back and do things that can really start to contribute to outcomes in a more meaningful way as well. And we're doing that through this organizational change management effort. We'll go ahead and move forward. Okay, I'm going to pause and get a drink. I've been talking a lot. See if there are any questions before I move to this next piece. Okay, so as I talked about in goal 1, and something that I know is important to so many of you, we have the largest market share in New Mexico when it comes to healthcare coverage. I think you saw we're now somewhere around 46% in total, 43%. I keep messing up the percentage because it just changed and I can't get the number in there yet. But that means that we have a huge responsibility to make sure that providers are appropriately compensated. When we came on board in 2019, we did an assessment of the E&M codes, and we did that because we found them to be the highest utilized codes in Medicaid. That's the evaluation management codes, and found many of them to be well below the Medicare rates. So we took all of those codes up to 90% of the Medicare rate, and or if there was not a Medicare rate for a code that we were looking at in the behavioral health arena, for example, we instead looked at the region that surrounds us and tried to come up with a regional average that made sense to serve as our benchmark, and took those codes up to at least 90% of that regional average, or potentially the regional average if we could. Like I said, that effort stalled because of the pandemic and the state of our budget for the last year and a half. But now we're ready to start moving forward on that goal again, we hope, and working in partnership with you all in the legislature and the governor's office to figure out how we invest in the right places in a strategic and equitable way throughout the Medicaid program. Sometimes it does end up that kind of the folks with the loudest representation and or the closest proximity end up kind of getting needs addressed sooner. And we want to make sure that those folks still get their needs addressed, of course, but we also want to know about the folks that we don't get to hear from. And so to do that, we have begun a contract for a comprehensive rate review. And the first step of that, we can go ahead and move forward, of that effort will be to engage in a baselining effort. So it's so little, sorry, Larry, it's so small, but I promise to talk you through it. I see folks leaning in up there. So we, the first step of this will be to baseline all of our rates. So by April, the plan is to have basically gone through all of the codes and all of the program areas in the Medicaid program, and to get a clear outline kind of by the provision of coverage, and you'll see these buckets in a minute because I'm not articulating it very well, and get a baseline of what our rates are now. And then the second piece is to go through and create those benchmarks like I talked about already. So either using Medicare or using a regional rate if there is not a Medicare code. And for those of you who aren't as familiar, for example, OB is a good place where there's not always Medicare codes, but we need some sort of benchmark to make sure that we're keeping up with the cost of care and also what's being paid in the surrounding areas so that we have competitive pricing for things and can actually keep practitioners here. After we complete that phase, we will be gathering stakeholder feedback for phase one. So we want to show you all that. We want to show you, okay, here's where all of our rates are, here's the benchmarks, and here's the difference, right? Here's the deficits in each of these areas. So, okay, over here, we're doing pretty good. We're actually pretty close to 100% of Medicare. But over here, it looks like we're at 58% of Medicare, and those look like areas we probably want to start focusing first. Now we have other things to consider in that conversation. Like, is that code ever even utilized? So does it matter that it's at 58%? And that's where we want to hear from you all. So that will be kind of that stakeholder engagement after phase one. That'll be the benchmarking report that we expect to come out from the contractor in April. And then we will move into the final report. In the final report, there will be there's one more opportunity for stakeholder engagement after that, and that's working on the strategic plan that comes in the final report. After we have those engagements, what we will be working on with the contractor and what we'll see is this overarching strategic plan that says, okay, this is the priority areas, this is where you need to start if there are funds available for you, New Mexico, to raise rates to be appropriately compensating for services. And then talk about how we keep up, right? So there are kind of things in statute. It's all different though. It's in reg, it's in statute, where we rebase rates and how and when and using what calculation is extremely varied. And we want to find a way to try to make this more equitable so that folks also have clear expectations. So that you know, okay, 3 years from now, it's not going to be at the discretion of the Medicaid program whether or not they'll rebase our rates. It's going to happen. So we know what's coming and we can make our budgets as well, you as stakeholders and providers and important partners. So that's the goal of this effort. I'm very excited about it, if you can't tell. And I'm really looking forward to all of your participation in it. So we can go ahead and move forward. I think there's a little bit more detail about what this is going to look like, but that final report coming out as we kind of close out this year, next year. So in phase two and phase one and phase two, I said we were going to try to look at the rates in kind of chunks and by provider types. Wow, for some reason that font shrunk as the slide was getting put together. But The first group is non-institutional providers, and the second is institutional. The reason that we started with non-institutional is because of federal opportunities that we have available right now to us, and we need to understand where we should be investing those federal dollars as quickly as possible so that we take the most advantage of that opportunity as we can. So for example, obviously the HCBS services, as we are revisiting what our postpartum coverage looks like, we want to look at what our pregnancy coverage looks like altogether. And so have that maternity set of coverage on the physician side covered here as well. Should say practitioner, not just physician, but we'll fix that. And then also kind of a passion of mine, and I know a lot of the teams right now as well, we really want to start focusing on the EPSDT, or early and periodic screening, diagnosis and treatment services for kiddos. And that also gives us some opportunity under those federal HCBS funds as well. And then finally, we still have a lot of work to do in behavioral health in New Mexico, and so want to make that another part of this phase 1 effort as well. Phase 2 is so small, but it's got nursing facilities, outpatient hospitals, inpatient hospitals, for example. And we will blow that up before we will share another version of the slides to you all. Okay, go ahead and move forward. Okay, I'm going to breeze through this for sake of time, but this is kind of the first crack at this from our contractor. This is the evaluation criteria that they are thinking about using that we presented to the Secretary's office. They've already given us some feedback on this, so we'll be adjusting this a little bit, but we wanted to put it out there and give you all an opportunity to weigh in even at this point as well. So if you take a look at this and you want to share, please, that feedback, please do so. I think the best way to do that, Melody, can you think about the best way to do that with Alicia quick here and pop it in the chat if folks have feedback, where you want them to send it and how? Probably with like a single subject line so that somebody can filter by it. So we'll put a plan for how to send that feedback in the chat. And then the next slide outlines the stakeholder feedback approach. So we'll have an initial outreach. There's groups that our contractor will be reaching out to you all to interview. And then we will be looking at any variation in the approach that we should be considering based on provider groups and their feedback. Then we'll be thinking about timing and considerations for the legislative session. So obviously, our budget is already pretty much done as we head into this upcoming session. And we need to get ourselves pulled out of this deficit and out of the public health emergency. So engagement with stakeholders on really trying to talk to the legislature about increasing any rates would be as we head into the session that would begin in calendar year 2023. So we're trying to think about the timing of all of that as we engage with you all and making sure that we get every key stakeholder group to be able to weigh in. Okay, the next steps are fairly internal, but we will be identifying those key stakeholder groups and reaching out to you. If you are particularly interested in participating, please also let us know through whatever option Melody is going to outline in the chat, and we will make sure to include you in those stakeholder sessions, as well as obviously giving you updates here in the MAC. Okay. Oh no, it's me again. I needed to find a way to switch up and have people in between me here. I'm going to pause again. We can move forward to the HCBS spend plan section. But I want to see if there's any questions about that comprehensive rate review.
Let me just say, Nicole, it's very comprehensive. So I think you've given us a lot of detail.
We hope so, and we hope that is a way for things to be feel more fair going forward. I think folks have always had the best of intentions, I believe, but I think we need some better documented processes that are also shared externally so that everyone has a shared set of expectations. Okay, Thanks, guys. I see some notes in the chat. It's really helpful. With exclamation points. I'm glad you all are as excited as I am. I could not be more of a nerd right now, but I'm excited about it. All right, so I'm going to talk about HCBS really briefly, and then I hope that I'm turning it to someone else. I think that I am, but I wanted to give you all an update. I think that you'll recall that we have this opportunity out of the American Rescue Plan Act. This is a separate bucket of money. There's money that came to the state through the American Rescue Plan Act. This is money that is separated and entirely designated for home and community-based services. We cannot use it for anything else, and it comes directly to the Medicaid agency. It comes in the form of additional match, and so I wanted to make sure that folks were clear about that. It sounds like there was some confusion previously about if that was money that may have also been being requested to be used for other things. That's not an option here. This money comes actually in our most recent technical assistance calls with CMS. We understand further, as they understand further, how they will be sharing this money with us, and it won't be even coming in a lump sum kind of fund transfer to the state. Instead, it will come to us as a reduced general fund need for the activities that we currently allow for reimbursement for in the Medicaid program. And it will also result in a reduced cost for those things that we invest in as part of the spending plan effort. It's probably confusing, but I'll try and explain it more as we move through. So this is the section of the American Rescue Plan Act, just so that folks can keep it distinct from other funds that have come to us. It passed on April, I'm sorry, it actually passed in March, and the funds were supposed to be available on April 1st. However, we did not get guidance from CMS until May 13th. States' plans were then due. The majority of us submitted them on July 12th. We did not get feedback from CMS until on our plan until September 27th. We had a 2-week turnaround to get them a response. We did so. We responded on October 15th to the questions they had about our proposal. And I have very exciting news, hot off the presses. We actually got our partial approval on Friday evening from CMS. So we are still digging through exactly what has been approved and what we can spend funds on in that partial approval, and we will make that public on our website. I know that I got an inquiry from Ellen Pines. I don't know if she's on today. She usually is. About the publishing of the RAI and our response. I'm sorry, the RAI is a request for additional information and our response. And I thought it was up. I apologize. I think I said that in a hearing and it wasn't quite up yet, but it should be now. So hopefully you all can find it on our website. Somebody can probably pop the link in the chat as well from the team. And then as soon as we make our way through this partial approval, we'll also post that for folks. Thanks, Ellen. I'm glad you found it. I'm sorry. I did see your note. I told the team to double check. So I'm glad that it is up, and we will share this partial approval as well. We're just digging through it a little bit and want to talk to CMS and get some clarity, and then we'll post that and certainly be talking to you all about it again. We can go ahead and move forward. So you all saw this before, but just a reminder, this is how Congress decided to define home and community-based services in the statute. So these are all the areas that we can look to both draw down the extra money, the extra 10% funding on, and then also the areas that we can reinvest that money in. Some of the ones that are pretty critical that we've been talking about recently are personal care services, home health care services, and a number of these, but those are some that came up in LHHS recently that I know a number of you have been kind of keeping track of. So we'll talk about those a little bit more here. We can go ahead and move forward. This just talks about how we draw down the funds, that we cannot reduce the program in any way a similar kind of maintenance of effort requirement as we saw under the public health emergency, but for the program at large, this is specifically targeted at HCBS. And the money has to be used to enhance, expand, or strengthen any Medicaid home and community-based services activities. The money is to supplement, not supplant. So we can never use it to say, okay, we currently spend, I'm making up these numbers, but 100 million on personal care services, and we have a general fund need. So we are going to use these federal funds to cover that $100 million expenditure in personal care services and free up those general funds to pop back into our general fund kind of revenue bucket. We can't do that with this money. It has to be to do new services that supplement on top of our existing expenditures. So to give folks a sense again, we currently spend about $1.2 billion annually on home and community-based services. So the initial 10% match, thanks Melody for keeping up with my chat request there. So the initial 10% match equates to about 120 million that we would get to then reinvest over the 3-year period. So we're super excited to see what CMS approved so we can get moving on all of those efforts. Let's go ahead and move forward. This was the example list of activities that CMS put out, and we can move forward. In the appendix of the slide deck, I believe, and if not, it's already in the one published previously, but we broke our spend plan into 4 overarching areas. There were 31 proposals. We are adding about 3 new ones as we submit our next plan here. But we expect to spend as much of that reinvestment in the first year as possible because that allows us the greatest match opportunity for all of this work. Go ahead and move forward. Okay, so a couple that I just wanted to call out because we didn't talk about this previously, but it did get announced at LHHS, so in case someone missed it, we've been working in close partnership with DOH, and our joint secretary currently announced at LHHS that we would be taking this opportunity to eliminate the wait list for the DD waiver over the next 3 years. It's a significant investment and one that we are really excited about. So in the initial spend proposal, what you would have seen is an additional allocation or an allocation of an additional 400 people in the first year. We will be updating that and asking CMS to support what will end up being about a 1,400 person allocation in year 1, as well as in year 2. And then we'll be working closely with the legislature and LFC and the governor's office about what happens when those federal funds are no longer available, which will be in state fiscal year 2025, 1 quarter of state fiscal year 2024. So that is a change that you will see us submitting. Another is an item that was just of a lot of concern when folks raised it. There are 3 ways in which personal care services are provided through the Medicaid program. There's more than that, but 3 main ways. One is through EPSTAT, so PCS services for kiddos. Then through the waiver, so for DD waiver recipients, and then through community benefit. The first 2 have rates that are published, EPSTAT and the waiver, and the community benefit program is a negotiated rate between the providers and the MCOs. The way that those rates play out right now, there's some pretty significant discrepancy. The hourly rates work out to be that in EPSTAT, the hourly rate is about just above $13 an hour. On the waiver, it's double that, about $27 an hour. And in community benefit, it's around $18 statewide. And so we need to address that discrepancy. It's the same kind of work, all for folks who really need those services. And we know that there are really competitive wages and benefits for folks For example, I know Target in Santa Fe is hiring for $15 an hour. And so we need to be paying a more competitive wage there. We haven't had an opportunity to address that in the past 2 years. We've talked about the deficit ad nauseum, y'all know, but we have this federal opportunity now. And then we have time over the next 3 years to work to build up our base so that we can continue those rates appropriately once we get through this federal funding period. But that upstat piece in particular, and making sure, especially given how many kids we take care of in New Mexico, is critically important. So I really want to thank the folks that brought that to our attention. And we are going to use this next submission to address that inequity and bring the rates into parity between, for now, upstat and the waiver. And we'll be working on how to even each of those out. Since they're all set differently, it's a little challenging, but that's going to be step one. So thank you all again for bringing that to our attention, and we hope that that will help alleviate some of the issues there that we know have been really problematic with keeping staff. So that's it. The next submission, we got our partial approval, so we are going to now submit one more updated plan with those 2 things I just talked to you all about, as well as a couple of others, and address any additional questions that CMS has for us. They do have more. We'll submit that back. But then our next full quarterly submission is due in January 16th of 22. If you all think we haven't taken advantage of an opportunity there, treatment foster care is one that we know we're working on and we need to be investing some more in. We know we've got some work to do with Secretary Hochul Lopez over there. And if you all think that there's any more we should be doing, you all should please make sure to be letting us know. Valerie Tapia is managing our plan. She's not here today, unfortunately, but Valerie.Tapia at state, I will put it in the chat. You all can reach out to her and we will make sure to be working with you all on anything additional we should be including. Okay, yay, I get to stop yapping at you all and turn it over to Dr. Bowen to talk to you about 988.
Thank you, Nicole, and I'm glad to give you a break. You've been really doing a fabulous job. So good afternoon, everyone. I do want to speak just briefly about the 988 planning and implementation, and we can go on to the next slide, please. 988, as I'm sure many of you have heard, if not all of you, is the new 3-digit number to call nationally for behavioral health crises, including suicidality, but not exclusive to that. And in New Mexico, we have been working for about a year now on the initial planning of using this as an opportunity to build out a more effective system of care for people going through behavioral health crises of all kinds. Excuse me. The current focus that we're really working hard on right now is the integration of 911 with 988. We fully expect for there to be confusion despite our best efforts to communicate to the people of New Mexico about the new system as it comes on board in July of next year. But for there to be confusion, and so calls that should best be sent to 988 may be made to 911 and vice versa. And in any case, we need a close collaboration with 911 because part of the model of 988 is that we adopt an air traffic controller type response to callers to that crisis line, which will be very different from the existing crisis system, where someone calls the line. If they need a referral, they get a referral, and then the call center is basically done with that episode of care. Under this model, there will be much more collaboration and coordination offered to people who make those calls. And in New Mexico, that is particularly complex since we have 46 different 911 authorities across the state, and we'll need to have a good collaboration between 988 and 911, and that requires technological upgrades and solutions, which we are currently working hard on identifying who can provide those and moving towards procurement of that appropriately. One of the other things we've been doing is reaching out to communities that have experience with behavioral health crisis and with the current behavioral health crisis response system across the state. And we've talked to a number of those different communities from a number of different modalities to extract, what type of 988 response system is going to be most effective and safe for people to access, so that we make sure that we respond effectively to their crisis, whatever that is. Let's go on to the next slide, please. And part of that is beyond 988, the call center's response and their interaction with 911, there's also a need for a different type of mobile crisis outreach and crisis receiving facilities. And that's that full system of care that we're talking about that's built for behavioral health. Because right now, the crisis response system that we have in New Mexico and across the United States is not really designed for behavioral health. It's other systems, which are very important systems for a well-functioning society, but stepping in and covering the behavioral health care needs. So as you can see on the slide, it will look for mobile crisis teams activated by 988 rather than 911 exclusively. And we already know that this is going to require different models of mobile crisis response, not one size fits all, because in a state as diverse and as complex and as large as New Mexico is, at least geographically, we need models that respond to the local needs, and that's what we're working on developing. The same is true of those crisis receiving facilities. Initially, we believed that the crisis triage centers that I'm sure you're all aware were stood up a couple of years ago, the very first one. Those facilities look like they will be adequate for our more urban centers in the state, but probably not financially sustainable. No matter how much Medicaid we use, not financially sustainable for our frontier and rural facilities. And so we're looking at other models to make sure that we have available to people within about 90 minutes of every resident of New Mexico, a safe place to go to help resolve that crisis and be inserted into an ongoing system of care. So I'm going to take advantage of this opportunity to also acknowledge something. I know that there has been the Behavioral Services Division, like many parts of the state government, we've been hit by the kind of mass resignation and people moving around as the hiring freeze went away. And so I just want to give you contacts for two very important people. I'd heard, I've been contacted by people who didn't know who to call within BHSD. So as you know, our Deputy Director for Policy and Prevention that was has moved on and has been replaced by Jackie Nielsen, and I'm going to put her email address in the chat as well. And that was Jenny Felmley, and then the interim deputy, the deputy for treatment and programs, Tiffany Wynn, has moved on to the early childhood education and care department, and so the interim deputy there is Hazel Melia, and I will put both of those contact email addresses in the chat so that everybody has a clearer idea about who to turn to. And with that, I have concluded. Thank you so much, and we can go on to the next slide.
Nicole, the next item on the agenda is the 1115 Demonstration Waiver Amendment number 2.
Yes, sir. And you guys are stuck with me again. Okay, but not for long. So thanks, Neil. I'm really excited about that implementation and planning effort there going on. So we just wanted to update you all on the 1115 demonstration waiver. Unfortunately, similar to Neil's comments, CMS has also had a big shift in personnel. And there are a number of states who happen to all have their 1115 waiver renewals expiring at the end of this calendar year. So their overarching waivers, like I was talking about for us, a big deal for programs when they expire. You've got to get them done. And CMS is having to prioritize those. And that has resulted in some delay in our efforts on our amendment. However, we have met with them many times to work through these innovations. Bryce Pittenger has been an awesome partner on the high fidelity wraparound piece. And the team has done a great job working on the IMD waiver. We are still working with them on GME. That is truly an innovative approach. No other state is doing that. So CMS has a lot of questions. It would be precedent setting. And so I think they want to make sure that they are doing something that they could broadly support across the country should they allow it here. And then finally, on the COVID-19 vaccine coverage, they've kind of told us stand down, don't expect any changes there, essentially, because they've released their guidance on what they intend to cover. But we have certainly still some questions about their expectations for states as a result. So if you'll recall, we can go ahead, I'm sorry, and advance the slide. If you'll recall, as part of that waiver amendment, what we wanted to do was make sure that we had an avenue to reimburse for vaccines for those individuals in our partial benefit categories. So pregnancy-related services or emergency Medicaid for non-citizens. And CMS has made some public guidance around covering the partial benefit categories, but the emergency Medicaid for non-citizens category has not been adequately addressed, in my opinion, and I would think the teams. And so we'll continue to work with them on that. But given what they have told us, we don't expect to see approval before the end of the calendar year. But we are very hopeful that maybe IMD and high fidelity wraparound would happen before that time. If not, hopefully early next year. But those are the first two that we expect to go through, and then still some work with them on GME, I believe, and COVID vaccine. So that's where we are. It's lagging along, unfortunately, with our federal partners also demanding timelines. So we'll keep plugging away at it. We can go ahead and move forward. And I think, speaking of Bryce Pittenger, Bryce is on to give you all an update about our engagement around the Kevin S. settlement. Thanks, Bryce.
Hi, good afternoon, everyone. Bryce Pittenger, CEO of the Collaborative. I get to work across departments on the Kevin S. settlement agreement with all these great folks you see in the Zoom room. Next slide. So there are, if you remember just briefly contextually, Kevin S. Was a lawsuit filed against HSD and CYFD on behalf of 14 children in child welfare custody. We entered into negotiations and we exited the lawsuit and formed a settlement agreement. And the 4 appendices or areas of focus in the settlement agreement are shown here on the slide. The first being creating a trauma-informed system of care. And those of you in the room that know about behavioral health, you know what this is. Those of you that don't, it's recognizing that the people that we serve have trauma. It's recognizing that sometimes we become traumatized in our service, and it's trying to prevent and mitigate both of those effects. Appendix B is about developing more appropriate placement options, reducing the use of congregate care when it's not medically necessary, and increasing kinship care and guardianship. So this is about really being able to identify family members, victim kin is how we call it in child welfare, which are people that are in the child's life but may not be blood related, and trying to place them first and foremost with relatives and with family, and second with victim kin, and third in a traditional foster care placement. Appendix C is about the Indian Child Welfare Act and really understanding the needs of Native American children that we serve, both in child welfare, CYFD, as well as behavioral health for HSD and all of you all. And Appendix D is about expanding access to the behavioral health services and really building and strengthening the workforce. Next slide. So I just pulled out some information on Appendix A, C, and D. I did not do B about placements just for the time limitations of this meeting, but if you are interested in an update about placements, I'll put my contact information in the chat. So Appendix A is really about how do we create a trauma responsive system of care, a system that responds well together, not just provides trauma-informed treatment, but a system that is coordinated and responsive. And so children or others don't fall through the net as they're transitioned to services or from services or their needs change. So progress to date is that we created, along with Dr. John Lyons and the Prayat Institute, the Child and Adolescent Needs and Strengths Assessment Tool for New Mexico. This is a very comprehensive tool. I'm really pleased with it. And this has been approved by the co-neutrals and we're good to go. We have built a portal to support the entry of data and the use of this tool for folks within CYFD and some providers. And we are live. We actually had a soft opening in September and we're on target for that deliverable, which is December 1. All children in child welfare will start receiving a CANS. And this is a communimetric tool to be able to tell providers what it is that this child has experienced, what their needs are, what their risks are, and what their strengths are. We have updated the criteria for serious emotional disturbance that was voted on at the collaborative in the January meeting of 2021 and passed. That is published and we can send you the link. The biggest pieces we did there to that is just to sort of take away the need for adjudication in terms of abuse and neglect in order for a child in child welfare to be eligible for that, as well as we expanded the definition. We are moving to an individualized planning process, which is really team-based decision-making. And so look forward, if you're a provider or you lead a provider agency, for folks eventually to get invited to our meetings if you're working with a child in custody. We have built a framework for training and coaching to include trauma responsive certificates training, and we're in the process of finalizing that. And we've created a coaching plan for the integration of training and coaching, because we know that you can't just train things, that you've got to coach, you've got to inspect what you expect, you've got to be able to provide the necessary support for people to change. And then an interdepartmental work group developed on the practice model and quality assurance improvement and evaluation plan. Next slide. Perfect. So this is Appendix C. This is about the Indian Child Welfare Act and about the Native children in our state. So what we've done so far is we've collaborated with tribes and pueblos across the state. We did draft a state ICWA law. It did not pass last legislative session. We have established an Office of Tribal Affairs and a position of Director of Tribal Affairs at CYFD. This is active. We have started to conduct ICWA out of preferred placement reviews, which basically means that if a child is in a non-native home, we want to know why, and we want to understand how to get them linked with their community. If there isn't an option at their community, we're still linking in, our intent is to still link in a liaison from the tribe, so we really understand what their needs are, what their preferences are, and how to support them. We have participated in Relative Connections, which is basically how do we do this? How do we create kinship navigator programs with a special focus on Native children and communities? And we're in progress with that. And then we basically are collaborating with the national ICWA folks to develop a system-wide training program. So more to come on that, but just real quick on the next steps. You can see here that we need to really understand how to develop a procedural plan for expanding services to culturally relevant services, treatments, and interventions throughout the state. We also are going to be looking at the possibility of developing the EMAC policy on cultural interventions as a component of our efforts. And I think that's it. Next slide. And then Appendix D is about expanding access to behavioral health services. Lots of progress to date on this. I'm going to skip the high fidelity wrap around because, of course, Nicole did a fabulous job talking to you about the progress there. We're waiting for CMS approval. We have completed all the other pieces, basically, including the rate development and the implementation process. We have published new regulations governing the medication use to ensure children in state custody are not over-medicated, if you need access to any of that information. And this is a partnership. This is between MCOs giving us the information, helping us understand what other alternatives could be. This is about our judicial partners and courts being able to ask the questions adequately. We do not want to over-medicate children on psychotropic medications in New Mexico, and we know that the child welfare population is the most vulnerable for this to occur. And so some of our next steps is we're working on some evidence-based practices that have been dictated by the settlement agreement, including functional family therapy, multi-systemic therapy, trauma-focused cognitive behavioral therapy, EMDR, which is eye movement reprocessing desensitization, and dialectical behavior, DBT. So a lot of acronyms there, but a lot of really good services that will really strengthen our community-based service network for children. So you can see here what's to come. MCOs are going to be partnering with us. Care coordinators are going to be coming to our individualized planning meetings, which is really exciting. We're going to be able to get them a copy of the CANs, of the Child and Adolescent Needs and Strengths Assessment, so they can really understand what the composite of this child and family needs are and strengths are and risks are, and work in tandem with us to create what we have had as a goal in this state for years, which is one family, one plan. We need to coordinate as a system, and that's the biggest shift here. So then the only other thing I'll mention is the HSD ride-along visits to monitor MCO care coordination engagement. With CISC is just children in state custody, and an acronym for children that are in our child welfare system here in New Mexico. So I think that is it, and I'm happy to answer any questions if time allows, and I will put my contact information in the chat.
Thank you, Bryce. Okay, we can go ahead and move forward.
I think Nicole, we're at item number 13, MMI SR update.
We're still chugging along, guys. So I think this slide is just the last one in the Kevin S section. If I didn't get through, but it was the combined LOD letter of direction for the MCOs that was published, I believe, last week or the week before, Bryce. That outlines a number of the things we'll be asking our MCO partners to engage with us on as it relates to the care of these kiddos. Kim, anything in particular you wanted to highlight?
No, just let folks know that this particular LOD is tied to Appendix D. So some of the commitments, 4 of the commitments, in fact, of Appendix D, and it was issued October 29th to the MCOs. And whenever we have something that impacts the MCOs, we issue a letter of direction, and eventually that will be rolled into the contract. So the contract amendment 6 or 7, I'm not exactly sure at this point. But then the link for where to find the LOD is right down here at the very bottom of this slide.
Nicole, I apologize. Can I add one small piece that Kim reminded me of? One of the biggest pieces, well, they're all big pieces of system change here, but is D.6.1, which is about children, children in child welfare, not being rejected or ejected from behavioral health services. And so again, if you're interested in more information about that, like Kim said, check that link.
Thank you, ladies. Okay, so I think we are now moving to the MISER update, which is our system replacement, and Linda is going to take that on.
Thanks, Nicole. So we just wanted to give a quick update on the Medicaid Management Information System replacement and where we are as far as timeline, and then just do a quick update to focus on the portal today. So next slide, please. Okay, so I did notice when I was looking at this some more that we do not have the descriptors for our modules, so we'll get that added so that you know what those acronyms mean, because probably not everyone has memorized them at this point. But this does give you the high level schedule of where we are with, you know, yellow focusing early on the procurement, moving into the blue, which is the design, the development and implementation, and then the yellow post blue is really maintenance and operations. So you can see from this that our system integrator, data services, and quality assurance modules are all in the design, development, implementation phase, in addition to our unified portal. So today, just wanting to focus on the unified portal and give a quick update on where we are with that particular module. So next slide, please. Okay. So our UP, or our unified portal, is one portion of what we refer to as our unified public interface, and it really is the second half to our, in addition to our consolidated customer service center. So that was implemented a while back, reflects the contact center or call center of our one-stop shop, no wrong door philosophy, where we took a number of different call centers and call lines and really consolidated those down to one in particular. And the unified portal is the flip side of the call center to actually have that web-based portal aspect. So it is our public-facing web interface. It's really focusing on transforming the delivery of our health and human services and really focusing on being unified and person-centric. So the unified portal roadmap here is really highlighting where our intent to start this work in January of 2022. So finalizing the contract execution at this point, getting final federal approvals and state approvals to execute that contract. It will have 11 sprints, as they call them, mostly with the work starting in January, just identifying all the work that needs to occur, and then that work will go out until October. So this is really an iterative approach where we will start with Behavioral Health Services Division, we'll move on to child support, we'll move on to our Yes New Mexico portal and our Medicaid web portal as they exist today, and then lastly picking up on the HSD website. So this is the effort now to take on the different portals that exist within the different divisions of the department and really integrate them into one front-facing portal for individuals and citizens to be able to have access to. So at this point, this is really just our external public-facing web portal. This is all external. We haven't started the work on what we will call the internal portal at this point. But just wanted to give everyone kind of high-level update of where we are with the portal, next steps, what's coming, what's starting in January, and all the work that will be occurring over the next year on integrating all of those portals into one. So anything, Nicole, you want to add, or always open to questions later as well? I know there's a lot of information to cover.
Yeah, thanks, Linda. So I think, you know, we talked to y'all about this a little bit a while back, but through the pandemic, we obviously had to shift priorities and resources. And so the project went through what was called a project diagnostic effort to reassess kind of our timeline, scope, and budget. And all of the secretaries on the executive steering committee, Secretary Hotram Lopez gets to participate in that one on here. I see her nodding along. They have been fantastic in kind of their governance role over the project as a whole, and trying to kind of make sure that it's right sized, that it's, you know, going to be completed in the right time frame with the appropriate resources and staying within a budget that we've outlined. So that is the timeline that you see resulting from that effort. And Linda, I didn't catch that in my review of the slides either, but we will send you all an updated deck. We have a really nice kind of like visual of what the project looks like and an explanation of those modules, and then how all of the enterprise agencies link into the project. And I think that would be helpful for you all to see. So we will share that. We'll send out one more version of the deck, like I said, with these couple of corrections I've noticed as we've been talking to you all. But it's kind of a hub and spoke model. That system integrator is kind of the the hub there, and then you've got all of these little modules that connect in, and then all of the enterprise agencies connecting in as well. And hopefully, as we move through the development and all of the phases of this unified portal, this is one singular place where our customers can come in and get access to all of the services and benefits that they need. That won't happen in phase one, so I don't want to overpromise, but over time, that is really the goal. And so this one is one that I think it's our most public facing module. A bunch of the other ones are, you know, the boring stuff that we do on the back end here. But this one is really making it easier and better for our customers to engage with us. And so look forward to sharing more as we start some of this development with you all. And because it is agile, we'll get pieces at a time. So hopefully we can show you all as we move along so you can see you know, what we've been investing in here and how it will hopefully make folks' lives easier. So thanks, Linda, for updating folks. And I think we are going to move into Roy's on. Awesome. We are going to talk about that Afghan evacuee population that I mentioned earlier on. And Roy Burt, who is our eligibility bureau chief, is going to take this one.
Can you hear me okay, Nicole?
I can hear you great.
Excellent. Thanks for that presentation on the Unified Portal. Really looking forward to that. I just have like 2 slides that we're going to share on Afghan evacuees. I know Nicole touched a little bit about it. It's kind of an unknown question mark in terms of the budget because we actually don't know how many individuals we'll actually be covering. This is a little bit busy slide, so sorry about that. The nice thing is our federal partners, the Center for Medicare and Medicaid, have been very proactive in dealing with the approximately 9 states who are currently processing Afghan evacuees. I didn't throw some numbers in the slide, but I do have some for you today. CMS sent us estimates of the estimated Afghan population, which are basically mostly residing on their bases. Like, for example, Holloman Air Force Base in Alamogordo, they're anticipating about 3,100 Afghan evacuees. Of those 3,100, about 45% or 1,400 are children. Then if we also consider our neighboring state, Texas, and Fort Bliss and El Paso, they're estimating about 10,200 Afghan evacuees there. So we're not sure how many will actually, we may get some settling here in New Mexico, so it'll be interesting to see how that plays out. Per the CMS has issued actually 2 guidance letters so far, or I should say facts. The first one was issued on September 27th, and basically in those facts they outlined 3 categories of Afghan evacuees. Those 3 are special immigrant visas, special immigrant parolees, and humanitarian parolees. What was a little disconcerting about that September 27th, 2021 guidance is that a vast majority of Afghan evacuees fall under what we call the humanitarian parolees group. And they were still qualified non-citizens with access to Medicaid. However, they would have been subject to a 5-year waiting period. And so the only thing they would have been eligible for in terms of Medicaid would have been emergency medical services category. And so that would have been very limiting. The nice thing is that on September 30th, there was passed a continuing resolution which enhanced the protections for humanitarian parolees by expanding their health care options. So basically, it was treating the humanitarian parolees the same as the other 2 groups, the special immigrant visa and special immigrant parolees, which means at the end of the day, they can all get Medicaid without a 5-year waiting period. And so this updated guidance that was issued on November 1st was great because it allows us, like I said, to cover these individuals under Medicaid. The first bullet there is simply directly right off the CMS guidance, which says almost all Afghan evacuees who are staying on Department of Defense bases or in a designated medical hotel can enroll in healthcare coverage provided by the Office of Refugee Resettlement. Newborns are also eligible for Medicaid, if they're born in the United States or if they're otherwise eligible. And then there's 2 groups of immigrant categories. There's one, the special immigrant visa group that I mentioned, and then all the parolees now, instead of being lumped into 2 groups, are now lumped into 1 group and all treated the same. They're all considered qualified non-citizens who are eligible for Medicaid, like I said, without a 5-year waiting period. One of the nice things too is that New Mexico is one of 39 states who has the CHIPRA 214 option in our state plan. We exercise that option. So we cover lawfully residing children under age 21 and pregnant women, keeping them exempt from the 5-year bar as well. So even if they had kept that, limiting humanitarian parolees to mostly EMSA services, we still would have been able to cover children under age 21 and pregnant women. But now, since this continuing resolution was passed, it makes it a moot point, and we can cover them under Medicaid. If by chance somebody isn't eligible for Medicaid, we can consider them for refugee medical assistance. But the fact is, a vast majority are expected to be eligible for one of our MAGI categories, whether that be our children category or our adult expansion category for adults ages 19 to 64. There's also, should they not be eligible for Medicaid, they can certainly apply on our state exchange, Be Well New Mexico, for marketplace coverage. The one thing, though, is that there is a intent to reside in New Mexico requirement, and that's our state residence requirement. So in order to qualify, they do have to attest to an intent to reside in the state. So that will probably be a limiting factor, and we're not sure how many individuals we're going to actually get settling in New Mexico. I did get some numbers on that. We currently have, like Nicole was mentioning, single digits earlier. We basically have 23 that have resettled in Albuquerque, and then there's another 24 pending. So the numbers are small right now, but we'll see how that plays out. Next slide, please, Melody, if it's you controlling the slides. So I mentioned the Office of Refugee Resettlement. They're responsible for facilitating enrollment for benefits in New Mexico with their affiliate Lutheran Family Services. And Lutheran Family Services is responsible for the coordination and submission of applications. So they can help somebody apply at Be Well New Mexico. They can help somebody with Yes New Mexico. They also work closely hand in hand with the Department of Health for screening. So if there's somebody who needs medical or mental health screenings, or even care coordination, they can arrange transportation. They'll refer the individual to the Department of Health. So they work closely together. In terms of ISD, they also have points of contact in some of the ISD offices like Southeast Bernalillo and some of our Dona Ana offices in Las Cruces as well. So they can answer their questions that they have. So it is kind of a coordinated effort amongst Department of Health, Lutheran Family Services, and the Income Support Division to try and serve these individuals as best they can and get them into eligible services. And there, we included in the slide some contact information, Las Cruces and Albuquerque for Lutheran Family Services, who's kind of spearheading the effort. So again, we're just not sure how many we're going to end up with on this population, kind of give you an estimate of the total numbers that I presented earlier. But that's what I wanted to present on. And if anybody has any questions, they're welcome to ask.
Thanks, Roy. Really appreciate that. Yeah, and the numbers are up since I talked to you all about it last. So appreciate all the coordination there and the monitoring the federal policy. That has changed quite a bit since kind of our first engagement with CMS. So appreciate you sharing that. And if folks have questions, feel free to bring them up. And then I think that takes us to our second to last item here. And is Charles, there he is. Hey, Charles. Charles is on to talk to you all about the COVID vaccination work group and the efforts that they've been engaging in. Take it away, sir.
Thank you. Good afternoon, everyone. I'm Charles Canada, the Deputy Bureau Chief for the Centennial Care Contracts Bureau here at Medicaid. And I've been working with Dr. Jeff Clark, who's our Medicaid Community Care Officer since April of this year, when the COVID-19 vaccination work group was established. The whole purpose of the group was, the work group was to form a multidisciplinary team to develop relationships and improve communication between the various departments of the state, the Centennial Care Managed Care organizations, and professional societies. Now it's grown to include 18 organizations who participate on several meetings a month. This includes New Mexico Medical Society, the Dental Association, the Primary Care Association, and the Pharmacists Association, just to name a few. The work group provides a forum where stakeholders can exchange ideas, raise concerns, and develop solutions around COVID-19 vaccinations. It's also a great platform to distribute information to the participants who can then take that information and share it with their staff and their membership. And this way we have consistent messaging and direction going to partners throughout the state. I'm very happy to say that other states are just, well, actually now beginning to implement the same approach that we started in April. If we go to the next slide, please. Through the work group, the managed care organizations collaborated to reach out to primary care providers to identify those who are administering the COVID-19 vaccine, and if those PCPs are not administering the vaccine, identify the reason and help them address any barriers. We've also improved the way we collect and analyze vaccination data. Medicaid's working closely with the Department of Health and the Centennial Care managed care organizations to synchronize our data collection efforts so that we're all using the same methodology and have consistent reporting. And of course, with the past couple of weeks, the recent developments around COVID-19, the work group is focusing on promoting and tracking boosters and vaccinating children and adolescents. Along with that, we've been developing approaches to vaccination events, ways to engage the unvaccinated population, and how to overcome their vaccine hesitancy. And I'll ask if Dr. Clark has any comments or additional information.
No, Charles, thank you. Great update.
All right, thanks, everyone.
Thank you both. And I'm sorry I did not see you, Dr. Clark. I would have introduced you as well. Thank you both for all of your work with that group. This has been a challenge across the country. As you all may have seen, Medicaid vaccination rates have remained significantly lower than national averages. And so we have been working through this team and all of their efforts to try to continue to increase our vaccination rates there and protect this population that is already at a significant disadvantage as it relates to the pandemic overall. So thank you. I know a lot of you are really active participants there, Eileen and others who I can see on screen, and we appreciate your partnership. Okay. We are almost done. Last but not least, we wanted to talk to you all about what's ahead. So we can go ahead and move forward. And at least share with you what we expect to be the dates for the MAC going forward. We really appreciate you all approving that change so that we could align with our budget projections. It makes scheduling this in advance much easier, and with all we have going on, it's very nice to have a plan. So those are the dates that you can expect to be meeting with us. It looks like spending your Valentine's Day with us, so we'll do something really nice for you. And then if we do see any shifts, we will make sure to let you know. And like I said earlier on, we will send out a Survey Monkey to talk to you all about the session related meeting and whether or not we want to do that in person and where. We'd probably request to do it here, the Medicaid building, just because it is big and we would have an opportunity to remain kind of socially distanced, which we would not in one of the rooms at the Capitol. So again, we'll put that out as we get closer and look forward to hearing from you all. And then last but not least slide, we have outlined some tentative topics. We've outlined some tentative topics for that upcoming meeting. We expect to have some new news on the public health emergency. Like I said, we expect to hopefully be able to show you all some more really detailed timelines for the procurement and the waiver. And then we'll have legislative activity to talk to you about and an updated budget, because by that time we should have both the LFC and executive recommendations on the Medicaid budget. So we could be talking to you all about what 22 and 23 will actually really end up looking like as we work with the legislature. So I think that is it, Mr. Chair, and thank you all for sitting with us for so long. Many of you really held out here all the way till the end. So we're happy to hear any questions. I'll let you close us out.
Okay. First of all, I want to say, Nicole, thank you very much for very comprehensive information that you provided to the committee. I think if you've sought to make transparency a goal, you have certainly achieved it. And we have reached that point also for public comment, but I will first take any questions that we've got from the members of the committee. Okay, seeing that there are none, I will go ahead and open it up for any public comments.
Larry,
Yes.
Larry, this is Dale Tinker. I did want to comment that just that the scheduled date for Medicaid meeting in the first one of next year is in the last 4 days of the legislative session, which will be difficult for some of us, and just wanted to express that.
Thank you,
Thanks,
Dale.
We can propose some alternatives to you all. I see that as well. Again, trying to align with the projection and what we expect to see come out of the executive and LFC. But in that survey that we'll send around, we will talk about some other date options as well. Thanks for calling it out.
Yep. Thank you.
Are there any other comments or questions? Seeing that there are none, Nicole, I'll just once again thank the staff and the many individuals who gave such great reports. I think we've got more information than I think any Medicaid Advisory Committee across the country has ever received. So it's very heartening and enlightening to receive this kind of information.
All right, thanks. We want y'all to know what we're up to over here. We really mean it when we say we want to be in partnership with you. So, you know, if meetings are too long or if you want us to cut back, let us know. But if you want us to keep getting it out to y'all, we're happy to. So thank you very much, Mr. Chair.
Well, thank you very much, Nicole, you and your staff and all the other people who contributed. If there are no further questions or comments, then I will entertain a motion to
Excuse me,
adjourn.
Larry.
Oh, yes. Do we have?
May I make a public comment, please?
Yes. Yes. Who's
My name is
speaking?
Kathy Smith, and I use Medicaid services. I'm dual eligible, and this just started this year. My health, my needs had increased, and my health has gone down. And I use Blue Cross Blue Shield for my centennial care. Now, from what I understand, I'm not the only one having this problem, but the transportation around the non-emergency medical transportation for people who are utilizing the Medicaid waiver and just Medicaid in general, I have had more rides canceled or no-show than have actually shown up. It's something that I have been working with my coordinator, with Blue Cross Blue Shield, and with Motive Care, who is the provider of services. It's also something that I understand is not a new problem. However, to have more, more rides canceled than actually be fulfilled, and to have no show, no calls happening for me when I'm medically fragile, I use a wheelchair. I need this to get to my doctor, and I have a good brain. Like, I can figure things out. I can, I thankfully my brain still works, but my body doesn't. And this is a service that I really need. And when I tried to make a complaint, it was like the Motive Care can't even talk to the complaint department. They have to send it over. They don't even have phone numbers. I had a man from the main office in Ohio call up, leave a message that he needed to talk to me. And then I found out days later that he canceled 3 rides on me without any explanation, without calling me back and letting me know. And so I happened to call him because I needed to change a ride and found out that he had canceled 3 rides on me. Well, I came to find out that because I take an assistant, because I can't push the chair myself, that it was that I needed a doctor's note saying my assistant could come. And they have a form. It took the man on the phone 15 minutes to find the form to send to my doctor so that my assistant could come with me. He couldn't even find the frickin' form. And I don't know that there's anything that you can do, but it was just something that I wanted to raise. And like I said, I know that this has been going on for a long time. And also, I wanted to let you know I was an advocate for New Vista's perspective.
Let me make sure we understand precisely what your situation is. You've scheduled transportation to healthcare providers, and it's been arbitrarily, oftentimes canceled.
I had 5 rides in a row canceled. 2 of them were no-shows, and 3 of them were outright canceled.
Mr. Chair, this is Sharon Huerta. I'm the CEO for Blue Cross Blue Shield. I'd like to offer Ms. Smith my number directly, or I'm happy to call you directly. I will look into this immediately. I sincerely apologize for that. You can have my direct cell phone number. I can give that to you, or I can take your number, whatever you prefer, and I will get to the bottom of this. I apologize.
And your name is Sharon?
Sure. My name is Sharon Huerta, Huerta.
I'm just finding you on the list of people, that's all. I thought that I would just, I thought Sharon Huerta. Sharon, I will send you my email right now in a chat message, if that's okay.
Sure, perfect. And
I'll send you my email and my phone number. But, you know, and my biggest concern as an advocate, you know, I was an advocate for people with disabilities for 17 years. My biggest concern is that I'm not the only one out there.
Sure.
You know, if this is happening to me, this is happening to other people. And, you know, as someone who is medically fragile, you know, and everyone who's medically fragile, our lifeline is our doctors. So I appreciate, Sharon, that you're willing to work with me with this.
Thank you, Ms.
Sharon, thank you for doing that. And if we see any patterns of any sort, please make that information available to the Medical Assistance Division. Okay. Do any other individuals have any comments or concerns? Okay, going once, going twice. Okay, 3 times. Okay, I'll entertain a motion to adjourn.
This is Christina Leeper, so moved.
Okay, thank you. Do I have a second to that motion?
Megan Lorino, I second the motion.
Thank you. Thank you. All those in favor of the motion, please signify by saying aye.
Aye.
Aye. Aye.
Aye.
Any opposed? Any abstentions? Okay, then the meeting is adjourned. Thank you all very much. And thank you for attending and sticking it out this afternoon. It was a very informative meeting. Thank you so much.
Thank you all.
Thank you.
Bye.
Have a good evening.
You too.